Hello, my name is Kelly Morton. My presentation is on the Ebola crisis. Let's start by getting to know the virus. In panel A is the Makona strain of the Ebola virus. They are filamentous particles, which is the blue worm-like structure you see. The Ebola virus falls under the Filoverdae family. And in panel B, it'll show the genus of the Filoverdae family and the different species of Ebola. Currently, this presentation is focusing on the last one, the most well-known one, the Zaire Ebola virus. So Fila viruses first target immune cells, and then with defective immune cells, the virus can start rapidly replicating, which they do in the cytoplasm of target cells. They inhibit the interferon molecules, which host cells use to hinder viral reproduction. And the virus triggers system-wide inflammation, fever, and damages tissue. The virus is spread by bodily fluids and by blood and pretty much contaminated objects from an infected person or animal. This is a small timeline of the early events of the virus. What's not shown here is the first discovery of a filovirus, the Marburg virus, in 1967. And then you have 10 years after that, later in 1976, the Ebola virus is discovered. The largest outbreak thus far was from 2014 to 2016, which resulted in 11,310 deaths out of 28,616 infected. The average rate of fatality in cases is 50%, with fluctuations of 25 to 90% in outbreaks. There is a current outbreak in the Democratic Republic of the Congo, so far with 64 confirmed cases, including the 45 deaths. This shows a quick outline of the three phases of the disease: the pre-outbreak, the outbreak, and the post-outbreak. It's important in the pre-outbreak phase to research the pathogenic potential for humans to help determine health threats and work models that can help with preventative measures and preparedness. The virus is regionally epizootic, which means it occurs mostly around the equator zones. It is a zoonotic pathogen that is maintained in reservoir species like bats, but can infect humans and other mammals, which can be end, intermediate, or amplifying hosts. During outbreaks, on-site sequencing technology has helped with diagnosis and improving outbreak response. And while in treatment, patient care has three components. It is supportive care to maintain or restore physiology, treatment of discomfort or distress, and lastly, presumptive treatment of any concurrent undiagnosed infections. Now, a quick overview of the virus's incubation, spread, and clinical symptoms and treatments. So incubation is 2 to 21 days, but most typically it's found that it's 6 to 10. Typically first shows as a non-specific illness characterized by malaise, fatigue, and myalgia. Then later it comes out as gastrointestinal issues such as anorexia, nausea, vomiting, and diarrhea. And as you can see on that first, the graph at the bottom, this is when it also gets more dangerous in terms of risk and spread, as the virus is spread by the bodily fluids and blood. Fluid loss is a huge danger during this time as well to the life of a patient, and they can lose up to 10 liters a day. Bleeding from orifices, which most people attribute to the virus, happens in less than half of patients. Here we see treatment plans spanning from the first trial drugs in 2014. Also at the timeline, you can see like all the outbreak of cases since then, since the first timeline didn't really show that well. What we're going to focus on here, though, are the two drugs in yellow at the bottom with the stars next to them, showing the FDA approval. These two drugs, in Nembes and a 3 antibody cocktail, and Ibenga, a immunoglobulin monoclonal antibody, are the only FDA approved drugs for treatment of Ebola so far. These drugs were considered to be a major break in the fight against Ebola. The 3 antibody drug as well is also shown to prevent against mutations of the virus, lowering a chance of drug-induced resistance. And that brings us to the ethics and importance of the Ebola crisis. So while both in Mazeb and Mbenga have remained largely unavailable in the Congo and DRC where the outbreaks are occurring, so even right now in the outbreaks, they're asking for help for that. The largest stockpile of both these drugs is in the U.S. This is because of different goals, politics, and financial worries of the stakeholders of these drug manufacturers, which have kept these drug therapies away from less affluent, affected communities. Even when publicly funded, the companies that have produced these drugs, there's no enforceable way to make them provide these drugs to where they're needed. And this can continue to play out in future scenarios where only the rich and privileged have access to treatments developed with public funds, which can lead to worse health inequality throughout the world. There is also an issue with humanitarian aid. Humanitarian aid needs to be set up to be sustainable prevention and intervention. What happens is they'll move in and they'll isolate, quarantine, set up field hospitals. Meanwhile, the rest of the community and the nation that is affected is suffering because they already have poor health care elsewhere, and there are resources being sent to this outbreak, and everybody else currently in clinics or hospitals suffers. So the emergency phase, it does affect long-term sustainable phase as well. A lot of humanitarian aid workers going into this are more about short-term results and don't think about the development phase. So what that involves is they need to talk to communities, teach, do outreach, and also work at hospitals, health centers, and clinic levels. In conclusion, from the Ebola crisis, we can learn how important preventative research is. And right now we'll see currently in our government, it's kind of put on the back burner. A lot of these drug trials, testings, and medical researches have lost their funding, and that will really hurt us in the long run. And that multi-nation and global response to disease could stop the spread, shorten outbreaks, and provide much needed aid to affected communities. When we don't work with our other nations or anything like that, and we remove ourselves from the World Health Organization, it lowers that response and puts everybody in danger. We need a thorough overwork and reflection on the medical development policies that we have so that we can prevent drugs and treatments from being denied to those who need them just because of how expensive they are or how rich a country is. And there needs to be more health-focused policies that protect the public and ensure these equitable access to treatments funded by the public. Humanitarian response also needs to take in short and long-term response to these outbreaks and medical emergencies and create a holistic approach with the communities they're helping, not just go in, run the show, test their drugs, and then leave that nation pretty much the same as when they got there. Thank you so much for watching my video.